is really to talk about the key concepts around Center of Excellence development. And really, in this particular case, talk a little bit about the esophagus and foregut program development, which we've had some success with, and others have as well. But illustrate really what we call patient-centered endoscopy, patient-centered procedures, patient-centered clinical medicine. Now, it's become a very important and very kind of a fancy word or phrase to talk about, but it takes a lot to be patient-centered on a daily basis from minute to minute. And then, of course, we'll finish up with some take-home points. So I don't know how many people in the audience are familiar with this particular plaque and this phrase. Of all the things that the Mayo Clinic does, this is the guiding founding principle, which is the needs of the patient come first. And this was actually enunciated first by the brothers Mayo, William and Charles, and it hangs at every of the Mayo Institutes. And I came to know of this about 18 years ago when one of my colleagues actually joined there as faculty. And we talked about this one night, and we were young faculty, all aspiring to, do good things. And he said, this is one of the first things that struck me when I walked on the campus. And this is something which was a big part of their orientation. It remains to this date. And we actually were just in India together last week in the big city of Jaipur. And we talked about this again and how difficult it is, but how important it is. And this, if nothing else you take from this lecture today, should be the guiding principle for the rest of your life in clinical medicine. If you do this well, everything else will fall into place. So with that caveat, what is a Center of Excellence? The Center of Excellence has been defined as a program, specialized program, offering high-level and high-quality interventions, experiences, coordinated in a way that is focused on a specific entity, specific disease state, specific skill set. And fortunately or unfortunately, medicine today has become highly specialized. And with that comes very high-quality interventions and experiences. But the whole goal of a COE is to develop a high-quality product that is based on excellent patient outcomes. And I'll give you a couple of examples. This is a story from 1999. My wife and I were both fellows in Philadelphia, and she was a budding interventional bronchology fellow. E-Bus had just started, actually, in Beth Israel Deaconess Hospital in Boston with a guy called Armin Ernst, who had learned from Felix Herth in Heidelberg, Germany. So Sandy had gone to Germany for a month and learned right from the source. So she's a budding E-Bus fellow, pulmonologist, and one cold winter in Philly, she slips and breaks her right wrist. And so as trainees with no resources, no money, no connections, now we are here with potentially a life-altering or career-altering injury. So we go to the Jefferson ER where she was a fellow. She gets her cast and everything. And they said, well, we said, where can we go in the morning to get this looked at properly? And luckily, somebody gave us the advice that there is a thing known as the Philadelphia Hand Center right next door. And so we went there. Now, since then, the name has changed. In 1999, the Philadelphia Hand Center had 11 hand surgeons on staff. 11. And when we talk about American medicine, there's a lot of negatives that come up, Medicare, healthcare costs, da-da-da. But when you need a specific thing done right, we still have the maximum bandwidth, depth, and breadth of expertise in this part of the world than anywhere else in the world. So I can attest to that in my global role with the WGO. There are many attributes that other places have, but depth of expertise is something that we have developed and do very well. So we went there the next morning, and as compulsive physicians, our landing time in the lobby was about half hour before our appointment time. So we go in, I pick up the Time magazine, and 5 minutes into this, we are brought in. The APP comes in. She takes off the cast, does the X-ray. The hand fellow comes in. There's a hand fellowship back in the day, even now. He takes a look, comes in, looks at the X-rays. 10 minutes later, the hand surgeon comes in. And our appointment was over by the time actually it was supposed to be started. And it was done beautifully by those three professionals. That left a mark on me. I said, if these guys can do it, we should be able to do it too. And of course, they gave the right advice. It was a non-operative repair. And, she's done well in the last 3 decades and moved on with her career in a nice fashion. Built 3 EBUS programs across 3 universities and so on and so forth. But if that had not been handled well, respectfully, professionally, competently, who knows where that risk would be today. This is another very special hospital in America that you need to know about. It is beyond a center of excellence. It's actually an institution that only takes care of when universities say this is the end of the road. These are the people who take you on. Okay. So in the nomenclature, it would be level 5 or level 6 quaternary center. So when esteemed universities say to you that your elbow is done, there's no more angulation we can get out of it, that's when you go to the hospital for special surgery in New York. Okay. They have patients coming from more than 100 countries now. And there's virtually no challenge that they cannot accept or will not take care of. They have people that have done entire careers in ulnar nerve rehabilitation. There is a center just for ulnar nerve rehabilitation. Now, it's an aspiration. Not every building, every center will be at that level, but I wanted to showcase this because I've had a personal experience with some friends who were sent there after they were told by the biggest institution in the country that nothing can be done. And now if you look at them, they can play tennis with you just like your neighbor. No problem. Okay. So it is possible to achieve a level of excellence even when the book says no. This is another example. Who knew that there was a hernia hospital in the world? In this audience, anybody knew that there was a hernia hospital in the world? This hospital only does hernias. It's in the textbook of surgery, both the British version and the American Schwartz version. And that's called the shoulder repair. The shoulder repair is a certain way of repairing the abdominal flap that does not require a mesh and it doesn't break any time in your life. You can ask your teachers and faculty here, any patient in clinic you've seen in America has always had a mesh. And very hard to do a hernia repair without a mesh. These people, that's all they do. When I first dealt with them, they're actually in Canada across the border. At that time, they had 18 or 19 hernia surgeons. This has grown way beyond imagination now. That's all they do. Hernia repair without a mesh. So if you're looking to aspire to a skill set in medicine, these are some of the examples that you can look towards and say, okay, if this is possible, basically anything is possible, right? I'm trying to advance this now. Oh, not just America. This is actually the hottest ticket in the world right now. This is King Faisal Hospital in Riyadh, Saudi Arabia. 600 liver transplants, including living donor and cadaveric. 600. That's just one of their areas of expertise. This is personally supported by the king and the current king, MBS. And it is actually attracting talent from all over the world right now. In fact, just last week, a guy called Ahmad Bazarbachi left a very big institution in America and joined them. So keep your eyes on this medical center of excellence. This is very forward-looking, and it's going to be in the news more and more. So this was just my attempt at showing you what is out there in this country as well as abroad, but also what is the maximum level of aspirational achievement that can be had in our fields across several disciplines. So what are the critical elements for developing some of these entities, even like a minute fraction of some of these entities? Well, vision. You have to have somebody who has a vision, who actually eats, sleeps, thinks, goes to bed, he or she, thinking about, I want to build something special. Without that, it's not possible. Second is resources. You can have all the vision in the world, but if you have no resources or no plan to get those resources, that's going to be very hard. But final, most important is commitment. If you have vision and resources, but you're not committed, all the resources and the ideas will go to waste. And that has happened as well. People have had many superstars come through the building, promised, multi-million-dollar programs, ROIs on investments, and nothing happened. And, things went down. So commitment is very, very important. At the end of the day, you have to roll up your sleeves and say, Let's get to work. So these are the important components. And of course, the granular level, you have to have the expertise. You have to have people who know what they're doing, and you have to be able to bring them together to do one thing together. And that's not easy. The approach has to be patient-centered. The leadership and governance has to be strict and focused. Another big thing about American medicine is protocols and standardization. Same thing like an airline pilot does in the cockpit. Immediately before takeoff and landing, there is a thing known as the sterile cockpit, sterile just like the OR. At that point, the flight attendant cannot come, no announcements can be made, air traffic control cannot interfere. I'm not a pilot, I just know this, I don't know why, but it's called the sterile cockpit. That's 10 minutes before takeoff, 10 minutes before landing. And why is that? Because it creates an environment of intense focus. So all the things are checked before you actually fly. So that's very important to have that focus. Care coordination, I'll talk a little bit more about that in the coming slides. Data-driven improvement, as opposed to some professor sitting there and saying, I think today the sun will be very bright. No, read the weather report, okay? Data-driven, this is very hard, even for very esteemed C-suites and for leaders, because they get personal bias into the equation. They're not looking at the data. The data is telling them things are not going well, but they don't recalibrate because they are biased. Of course, advanced technology and innovation is a critical part of all this, but no leader will invest in that. Dr. Hadar and I had this discussion this morning. We will not invest in that unless we see all the other elements being put together, because that's money down the drain. I firmly believe that research and innovation is the founding pillar for meaningful progress. And in the recent times, it's been difficult. But with some luck and with due diligence and perseveration, you should be able to get some of your protocols through, especially if you work with good collaborators who have a good reputation and you have a reasonable plan that you're presenting to the NIH or to the NCI. We got an NCI grant approved last week in collaboration with the Mayo Clinic, Prasad Iyer, and that will come through as well. So finally, of course, you need high quality outcomes. So this is a recipe for developing a center of excellence. This is not everything, but I think it's pretty much most of it. From all of that will come recognition and reputation. And once you hit that bar, it's basically autopilot unless you screw things up. Okay. But to get that to that point is about 5 years of work, at least. So why would I do that? What's the benefits? Well, the benefits actually are to every stakeholder in the room. The benefits are obviously to the first stakeholder, which is the patient, but all the way through the referrals, through the institution. And in fact, you can even develop preferred payer mechanisms where you can get a higher differential for reimbursement, and people are doing that. Obviously, if you have a beacon of excellence, people will want to come and join you. Nobody wants to go join a dump, but everybody wants to be part of King Faisal Hospital right now, right? So that's important to note. And then, of course, from good things come great things, and from great things come even greater things. So it's a self-fulfilling prophecy by the time you actually hit that bar. Now, how do you build it? Obviously, I talked a little bit about the vision. I talked a lot about the team. The team has to be skillful. They have to be able to work together. Individual skill set silos are of no use to me. They have to be able to work most of the time well together. And we were very fortunate to have that. I hear that you have a very good surgical collaboration here as well. Standardized pathways are important, and it's very important for nursing, for our ancillary team supports, because medicine has become sophisticated and challenging, and it's easier to follow a protocol and not deviate from that. And then, of course, investments and establishing quality mechanisms and so forth. So I've alluded to that. In the realm of the Foregut enterprise, these are the elements that are at play. This is not everybody, but this is like the big services that are involved. And I put pathology there because I remember back in the day when we were starting our esophageal program, Jeff Peters was a chair of surgery, and he was personally involved. And he was a direct descendant of de Meester, the man who developed the de Meester score. And they knew of a pathologist. I think it was at USC. His name was Soma. They called him Soma, and Soma was the final word in Barrett's pathology. So we sent our pathologists for a sabbatical to spend time with Soma. Now, in modern times, Soma is still around, but In modern times, there's a guy at the Cleveland Clinic. His name is John Goldblum, and he is the final word in Barrett's pathology, amongst a couple others. So don't ignore pathology. Don't ignore radiology. Radiology is all over the place. If you look at any CD or MRI that comes in from some of the suburbs, the reports are all over the place. And even in academic institutions, there is no standardized MRI protocols. We are trying to work with NYU using AI algorithms to build those MRI reading protocols so that every case is read the same way. But we are nowhere near that. But that's what's needed. You need buy-in from all these services to do the right thing. So we talked a little bit about patient-centered care, right? Remember that plaque at the Mayo Clinic? Well, this is what it takes. And I think for us in America right now, with the difficulties in staffing, the nursing shortages, the difficulty in recruitment, getting people into a building to work physically, not remotely, is hard. So care coordination is something that is weak right now, I think, in many areas. You have a lot of the other elements, but you don't have enough navigators, you don't have enough support staff. Scheduling it can be problematic. Access becomes a problem. And then another big box is patient education and informed consent, and the time and ability to give patients to choose options. That's another issue. And the next box that I have is family support. How friendly are our hospitals and clinics, how much time we spend with family, and how well we do that job of giving good news or bad news, whatever it is. I think that personability of engagement has gone away a little bit, and we need to bring it back. One big black box is post-procedure follow-up. You can do the most miraculous procedure in the world, but if there is no real follow-up ensured after that, it becomes very problematic. And the same is for POEM, same is for bariatric procedures, especially for bariatric procedures. Same is for Zenker's myotomies. These people don't just go away. They will eventually come back if you don't take good care of them. So that's important to do that. And then be open to feedback. From constructive feedback comes CQI, a term the Japanese taught us many years ago, continuous quality improvement. That's what the model Toyota was built on, continuous quality improvement. Don't look for that. You won't find it. You'll be worse off for it. So in the realm of Barrett's, I won't go through too much, but these are some of the academic slides. Why is Barrett's important in this country? It's not so much important in Africa right now. They have a different problem. They have esophageal squamous cancer. But we have this. And there's a lot of different things out there. I won't belabor this slide in the interest of time, but the Barrett's program lends itself very nicely to a Center of Excellence. It just so happened that last week, I got this referral from a university. And it speaks for itself. It says here, I will be retired or something. And then he said, the only place in the region that has such a Center of Excellence is that, go over there. So this patient came, he's 82 years old and with high-grade dysplasia. He's gone back and forth between treatment and no treatment. And now finally he landed in my clinic and we had a 45-minute chat with him. And he was like, all these years I was not sure, but today I'm sure. And I said, line him up. And, he was very nice conversation. We had a lot of jokes. He felt comfortable. I felt comfortable. He felt he was in the right place. And majority of the conversation, actually, to be honest, he had with my APP. And she's experienced enough to have such conversations. And we discussed everything because I don't know, I may have to do an EMR on him or an ESD. He may perforate. He may end up in an esophagectomy that day. So all of that was covered. And he felt very comfortable. And he will be treated in the next 4 weeks. That's the other thing. Now we've seen the intake. We can't just leave him till January of 26. So it's important to see that, once you develop something, the people will come. Particularly in the realm of Barrett's, the areas of emphasis are listed on this slide. Again, I will not belabor it. This thing is recorded. It hopefully will make it to an enduring material. But I do feel that in specialized work, at least we can talk about GI endoscopy. I'm sure it's the same for the cath lab. Standardized protocols are important. Data quantification is important. How well are we doing from point A to point B? And then, of course, bringing patients' issues to a collegial tumor board or a conference is very, very important. We have cancer conferences, but you also have benign disease conferences, and it's all out in the open. There's 60, 70 people in the room from every specialty you can imagine. And you have, these are recorded minutes. They are legally recoverable. They are protective in nature. because if a group of people came with the same idea, it's likely the right idea and it protects you as well. It's the right thing to do. So these are essential elements of programs like these. You cannot get away from that. You have a submucosally invasive esophageal adenocarcinoma, bring it to the tumor board and let the tumor board tell you that it's okay to do cryotherapy. You cannot decide that on your own. All right, so that's an important part. So guidelines. Well, guidelines are guidelines, they're not mandates, but they do strongly encourage a COE-based approach in the realm of Barrett's. And COEs operate on guideline-based principles. So it's a kind of a duality of relationship. And I'll just quickly skim through these. These are all the Barrett's guidelines were recently revised. And you can see here, high volume centers, expert pathologists. I like that they actually paid attention to that. Very, very important. And endoscopists were trained in all aspects of the disease. The closet has to have all the elements that you can offer. You can't be shipping patients from one center to another, typically speaking. So they belabor this point very adequately. And I wanted to highlight that's in the guidelines as well, because some people live their life by guidelines. So here it is. The Europeans believe the same. One other thing I wanted to point out, and this is a good example, is a concept of clinical practice updates. Clinical practice updates are mini guidelines between two big guidelines. The problem with guidelines is they only come out like 5 to 10 years apart. Each guideline takes 3 years to write, and it reflects data that was from 3 years ago. So the CPUs, which the AG has taken on this mantle, are very, very good when they come out. Sometimes they come out with flow diagrams. Just take them out, blow them up, paste it in your office or your lab. These are very practical pearls and caveats of what to do with a particular case and where the knowledge stands. So CPUs are good, and CPU is the only document where things like tissue cipher and CDX, wide area transepithelial sampling is included, at least have been commented on. So CPUs are very good. Quality metrics. Obviously, we have multitude of papers, and Dr. Fleischer will attest to it, that we are not doing a great job with examining the esophagus or wherever we are, colon included. We are not using advanced imaging enough. We are behind our European and Japanese colleagues in that realm. We're not biopsying adequately. We're not reading biopsies with any degree of consistency. Our follow-up intervals are all over the place. So we're not doing a great job, but yet we have to have some metric by which we measure ourselves and our programs. And this is a slide talking about that. So one of the ways we do that is by developing research registries or even non-research registries that are institutional, where we look back every so often and say, well, how many people did we do good by and how many we actually did not? So this is well, there was a plan to get paid based on this. We haven't quite reached that level yet, but in the future, there will be some value-based purchasing where outcomes will decide how much you get paid rather than time-based billing or complexity-based billing necessarily. So moving to the other side of this talk, research, innovation, technology. This is the trifecta for basically anything we do that is aimed at excellence. From good research comes innovation, and that innovation is eventually, some of it, not all of it, is commercialized. And when that's commercialized, you may get a crack at it in clinical practice. But this is the way it basically goes. It hasn't changed through the 100 years of medicine that at least we can look back on. Now, well, how is it relevant to our discussion? Well, you remember there's a couple of names here, Tom Watson was also a descendant of the USC School of Esophageal Surgery with the Meester. Tom and Jeff were in charge when I walked in at Strong. And this was one of the early papers. The surgeons came to me and said, we want to work with you. We want to develop a minimally invasive endoscopy program modeled very much on what Ken Wang had at the Mayo Clinic and Dave had here, and said, let's do 40, 50 patients and let's publish a paper. So they got it in the surgical paper, 2011. And believe it or not, around that same time, there were papers coming out that esophagectomy for high-grade dysplasia is okay. And so just wanted to highlight how our relationship started. The first two authors there were research fellows in the thoracic surgery department. Carolyn Jones now is the division chief. And Ginny Lytle has moved on to Boston. But that's how it started. And that legacy has continued. This is the SWOT PE trial, which is funded. It's, I think, a $8 million trial funded for checking whether a brush biopsy is going to replace forceps biopsies. Because as you can see here, the brush actually takes more circumference and surface area as opposed to pinch biopsies that may only take 5 or 10% of the esophagus. So this will be out in about 2 or 3 years, and will hopefully help us decide whether the Seattle protocol is no longer relevant. This is the $15 million servant trial, which we are also very lucky to be part of. And it's actually what we call a U grant. How many here have heard of a U grant? Everybody's heard of an R01 grant, a K grant. Nobody's heard of a U grant. A U grant is, I don't know, maybe later on Dr. Fleischer can elaborate, but it's basically the medical equivalent of going to the moon. So in the realm of GI medicine, there has not been another U grant that we are aware of that came through in our lifetime. So hence, this was pre-election, so $15 million. And this is basically addressing the issue of low-grade dysplasia. If you look at the guidelines right now, low-grade, you can watch or you can treat. That's been the case for 30 years. So this is the first formal trial that is looking at what to do with low-grade dysplasia. And patients are very hard to recruit because this is a paradigm-shifting research. And that is why the NIH gave it the U grant. So about 5 more years before we find out what happens, but we are in the thick of it. And these are the centers that are part of it. And if you look at it, this is a big country, but only then still you have only about 20 centers. And these are the centers. They are not picked because they are friends and family of the NIH research team. They are picked because they have the ability to deliver the level of research that is required for this. Each patient takes about 100 hours of work, roughly, between the selection, the scheduling, the procedure itself, the handling of the specimens, the phone calls, the Zoom calls, the mailing, the shipping, the da-da-da. That's a lot of work. And so, but a true hallmark of an excellent center is that if you are able to position your case to be part of such research, because from this research will come true innovation and will also help not only propel careers, but also paradigms, growth of the departments, reputation, visibility, and all the good things that come, and more research comes with this. So that's important. Technology, I still feel it comes from research. It is relatively subservient to research. It serves a great purpose, but it doesn't just come out one morning from the toaster. Technology doesn't come from toaster. It comes from many years of work behind it. So when you look at technology, whether it's high quality EUS, imaging, cryotherapy, it came from years of work. And that work is done in many places, including this multi-million-dollar purpose-built animal lab facility that's only an hour from my place. I was there at the inauguration. It's at the Jacobs Institute. The Jacobs family supported this with, I believe, a $500 million grant. And amazing place. If ever there's an opportunity, I would love to have fellows and faculty here join us. The opportunities here abound. This is our collaboration with SAGES, which is a society for GI surgeons. Jeff Ponsky was a luminary there. We have many young people, mid-career people. And this is the annual SAGES course for flexible endoscopy. And after today, if there's any interest, we can have many of you join us as well. But this will be held at this facility, and it's an all-day activity with live animals. And this is where you actually learn. You learn specific techniques, you build relationships, and with appropriate planning, good research comes out of that as well. This is my last time there. And you can see the facility and the joy with which we collaborate with our surgical colleagues. This is an experiment that came from such an animal lab. This is an ablation that you have not likely seen before. This is called vapor ablation. This is steam, and steam will fix the esophagus at some point, not yet. But it's pretty cool, right? So this is another device called the endorotor I was involved with. And it basically takes out the mucosa with a powered high RPM blade that suctions things in. You can see what happens to this colonic polyp here that was EMR'd and ESD'd and ultimately required the endorotor. Look at this. Basically a non-thermal dissection. So this is around. It's also helping us with pseudocysts to remove the debris. This also was many years of animal research. I remember doing a pig lab with this at Case Western many, many years ago. I already talked about this. Predictive analytics, this also came from research. This is still under a big part of research. It's part of the servant trial as well. This is a $5,000 commercial test that is being tested as part of the NIH study as well. What about outcomes? Well, so at the end of the day, when we developed this, we were in the middle of it. We said, well, let's look back at our 10 years. So this is a paper that got published. This was our 10-year experience. And if you look at the numbers here, the complete remission, 75% for Barrett's, dysplasia, 98%. By comparison, the randomized control trial in the New England Journal, these numbers were in the 60s, and I believe in the late 70s and early 80s. So with multimodal therapy in a dedicated program, outcomes that you can achieve can be quite mind-boggling. I can't forget about patient advocacy, because this is a big part of any good center. You need to be engaged with these organizations. Patients will have a conduit to these. This will show you in good light. They will be grateful for this. And the advocacy organizations will be very, very happy to join forces. So we've had a couple of them stateside, and then there's obviously European counterparts as well. Similar principles apply in bariatrics, the same concept. When we first developed it, I remember I was telling Sherwin, we met with the chair of medicine and said, we need cardiology, endocrine, physical therapy, nutrition, anesthesia, everybody on the board. And we started with the Orbera balloon. That's all we had those days. It was $8,000, and that got split up between 14 specialties. And of course, now there's a lot of guidance on this, and these are documents that and entities that kind of speak to that. So I won't get too much into the details with that, but there's a volume issue, there's a multidisciplinary team-based issue, equipment, of course, and then triaging patients for who gets what. There is a joint document that just came out between the European and American societies on this. So the ASG is really leading the way with this. And so if you want to set up a endobariatrics program or a bariatrics program, it's not a solo event. It has to be done with some partnerships. Now, the new kid in this area is not just any more balloons and sutures, it's actually metabolic endoscopy. And so we have a couple of areas that are, you want to really get involved with cutting edge research and implementation. So you have the duodenal mucosal resurfacing device, and you also have what they call the electroporation device, the reset device. So more to talk about that offline, but we're moving away from physical restraining devices to actually altering the physiology. The second duodenum is a very active space, and that's being looked at very, very closely right now. These are the plethora of devices available for bariatrics. I won't get into that, but it is going to get simpler from a procedure perspective. That's a big focus right now. It's going to get more metabolic. And of course, you have the GLP-1s, which is not the focus of my talk today, but keep an eye on that. And it'll be some form of combination systemic and endoscopic therapy that is yet to evolve. We did a recent review, actually did a research review of an excellent bariatric team at the Cleveland Clinic. And you can see here, the focus of this review was not necessarily to say, well, what procedure, how many, da-da-da. It was actually to talk about what's the team? What does it take to make an excellent team? And you can see here, the lead psychologist is part of that discussion. Everybody was given equal priority in that review. It's available online as part of our special series. That's my APP, Sarah Enslin, and she is a co-editor of this section. In this journal, that actually goes to about 30,000 homes, GI homes in the country. So, we just did that. Quality metrics, same with any other thing. There's specific metrics that you want to look at. POEM is the same story. Very grateful to our surgical colleagues to help us with developing the POEM program. It got hit in COVID because of the elective OR situation on hold, but it's back up now, and we're doing very, very careful case selection and doing them in conjunction with the surgeons. Again, the requirements for a good POEM program are listed here. Motility is a big part of it. So basically, the message here is that POEM is not a procedure, it's a program. And so everybody who wants to build it should build it just like they would build a metabolic program or a cardiovascular program or anything else. Not a procedure, it's a program. So look at all the aspects of it in detail. Again, a lot of guidelines on this. A couple of slides on the role of APPs. I learned last night that there is a huge APP contingent here, as do we have. And this is across endoscopy, general and therapeutic, but mostly therapeutic. Their evaluations with you, their peri-procedure management, their ability to support communication, their own professional development. I heard there's a couple of great leaders here on site in the APP team. They're liaising with the surgical colleagues. They do amazingly well when they work with nurse navigators or APP navigators from oncology and surgery. It's like a whole different world that you don't even know about, but that can develop and should develop because that's what's needed. I'm a big believer in doing academic work with APPs. You just saw an example of a great review we did. And they have now increasing recognition in societies and in journals where there are APP corners and sections, and they are rising to the level of associate editors as well. So build those teams and be part of that. We wrote a recent review in a top-tier journal on this topic as well. This is basically the message. They are involved with direct patient care all the way around the clock to research and professional development, and of course, leadership roles nationally. So guiding principles, finishing up here in the interest of time. Well, I've talked a lot about already the building of the expertise. That's really the key. The institutional readiness is very, very important. The vision, the support. Don't forget your ancillary team members. And of course, all the things that we talked about from an infrastructural perspective as well. Third thing is very important is always think multidisciplinary and involve people early. It's important to get a culture of collaboration early, because if people don't trust you across service lines, it's becoming very difficult. It becomes very difficult to position the case and be successful. So the problem comes is when you've already made some inroads and people find out later, that's not a good place. Then you have to kind of restructure that conversation a little bit. So start early, go together, and then wherever you land, you are there together. All right, that's important. Let's see if I can move this along. Number 4 is patient selection. After you've built the program, and if you're indiscriminate about your selection, about your interventions, about your patient outcomes, it will speak in your outcomes. It will speak in your reputation, and it's going to kill all the good work that you've done, all the years that you've built up to that. So patient selection and patient focus is very, very, very important. Finally, of course, looking at the outcomes, you have to look at what have you done, how well are you doing, report it, measure it, publish it, speak about it, and take back constructive feedback and revise and recalibrate. That's the hardest part, I feel. As physicians, we are not very good at taking constructive feedback even and applying that to our development. I already spoke a lot about research and innovation and the amount of time needed to think before you act and do things in a scientific way, in a logical way that makes sense, and bring a research idea through innovation, commercialization, and to clinical application. Not easy, but we actually developed a whole podcast on that for ACG under the technology committee, which I chaired for a few years. Lessons learned, there's a lot of lessons. I learn lessons every day, and my wife makes sure that I learn more lessons every day. But poor patient selection, I feel. When you are endowed with skill, with reputation, with support, with name and fame, and with the ability to do a lot of things, it's human nature to do things. And I think the brakes have to be applied and said, let's look at the patient. Let's look at what the patient needs are. Remember the first slide. Does this patient need this procedure? And that's what the episode trial was all about for ERCP, for abdominal pain. And 12 years later, there is still a lot of ERCPs being done for abdominal pain, which is malpractice. So patient selection. Number 2, skipping the standardized pathway into a shortcut. Shortcut is never good. So if you don't have time, it's 5:30, don't start an ESD. No, that's not the good time to do it. Be bold enough to tell, or it's an inpatient, no, we'll do it tomorrow. We'll do it tomorrow when we have time. Or if the patient is on Plavix, it's only a 3-day hold and you need a 5-day hold, don't skip 5-day hold. If you're doing an FNA, that's it. That's your unit policy. That's positions the patient for safety. A pancreatic mass can wait 2 more days. It's okay. So don't take those decisions that are skipping standardized protocols. That's when people get in trouble. And then my personal favorite is neglecting staff buy-in. If staff is not ready, they may be afraid or hesitant to tell you, but you need to elicit that from them. Are you ready? Are you good? Are we good as a team? Because they will underperform if they're not ready, and the patient outcome will not align with your vision. So it's very, very important to have the people on the same board. So last slide, new program development is a lot of fun. I've had the great privilege of doing a lot of it internally, externally as well. I remember a time I traveled to a university to help start their Zenkers program with a new knife that Olympus had just came out with. Fun time, very fun time. And we started a program for another center. But it's not easy work. It's a lot of work. You need to have a lot of solid visionaries with you, behind you, above you, leading the way. You need institutional support. You need focus. You need collaboration, data to drive your decisions. And then, of course, through research and innovation, you develop a better clinical program that actually results, hopefully, in better patient care. So I'll stop there. I'm sorry for the long talk. Thank you.